Imagine a life-threatening condition where your body's sodium levels skyrocket, and doctors are split on the best way to fix it, fast or slow. Severe hypernatremia, a critical imbalance of sodium in the blood, has long puzzled medical professionals. But here's where it gets intriguing. A groundbreaking study from Korea has just revealed that two drastically different treatment approaches, rapid intermittent bolus, RIB, and slow continuous infusion, SCI, yield nearly identical results in terms of safety and effectiveness. Yet, the rapid method has a surprising edge: it corrects sodium levels faster while using less fluid. And this is the part most people miss. Could this finding simplify how we treat this dangerous condition, potentially saving lives with fewer complications? In a randomized trial led by Sejong Kim and colleagues, 178 patients with serum sodium levels of 155 millimoles per liter or higher were divided into two groups. One received rapid, intermittent doses of electrolyte-free water, while the other got a steady, slow infusion. The goal: to see which method could safely and quickly lower sodium levels to safer thresholds. The results, set to be presented at the 2025 American Society of Nephrology Kidney Week, are eye-opening. Both methods achieved rapid sodium correction in over 88% of patients, with the RIB group showing a slightly faster drop in sodium levels within the first 6 hours, -4.7 millimoles per liter versus -3.6 millimoles per liter for SCI. Even more striking, patients on the rapid protocol required significantly less total fluid over 48 hours, which could reduce the risk of fluid overload, a common concern in hypernatremia treatment. But here's where it gets controversial. While both methods were equally safe and effective, the rapid approach's efficiency in using less fluid raises questions. Should hospitals adopt this method as the new standard, or is the slower, more traditional approach still preferable for certain patients? The study's authors argue that the rapid method's simplicity, eliminating the need for complex electrolyte calculations, could make it a game-changer for resource-limited settings. However, critics might argue that the slower method's predictability is still valuable in delicate cases. The findings also challenge the notion that faster correction always leads to higher risks of overcorrection. Both groups had similar rates of overcorrection, around 15%, and 28-day survival, suggesting that speed doesn't necessarily compromise safety. This study not only validates the use of rapid correction but also opens the door for further research into optimizing fluid management in hypernatremia. What do you think? Should the medical community embrace the rapid bolus method as the go-to treatment, or is there still a place for the slower, more gradual approach? Share your thoughts in the comments. This debate is far from over.